Now, at the moment in the UK, about 4% of our population are diabetic. And the majority of these patients with diabetes suffer from type 2 diabetes mellitus. So of the 4% of the population who are diabetic, maybe about 90% of these have the type 2 form of the disease. And when I was a student, I was taught that this was a maturity onset diabetes mellitus. And this is basically true. The onset of this disease is in adult life typically, and middle and later adult life is when we often see these patients presenting. And we also used to describe it as an NIDDM, a non-insulin dependent diabetes mellitus. And this was to contrast it with the type 1 diabetes, which clearly was insulin dependent, because in the type 1, as you remember, there is an absolute deficiency of insulin, the body producing no insulin at all. Whereas in type 2, patients could survive on dietary modification and oral hypoglycemics. They would not die if they weren't given insulin, as type 1 patients will die if they're not given insulin. We now know it's actually probably a good idea to give insulin earlier than we have done in this condition, but that's a slightly separate issue. But it is still sometimes described as an NIDDM. And although this is diabetes mellitus, the characteristics with type 1 are somewhat similar in that you get a hyperglycemia with both, but the mechanism of the disease is very different. So let's think about what is going wrong now in type 2 diabetes. Well, type 2 begins with the insulin receptors. Remember the membrane-bound protein insulin receptors, the transmembrane insulin receptors on the surface of many cells, floating in the phospholipid bilayer of the cells. The disease begins with these insulin receptors, and the insulin receptors stop working properly, or they reduce in number, or both. So there's a reduction in the number of insulin receptors. And if you remember the physiology, if the insulin receptor is stimulated, that brings the glucose transporter proteins to the surface of the cell. So if there are less insulin receptors to be stimulated, less glucose transporter proteins rise to the surface of the cell. That means less glucose is transported from the blood and tissue fluids into the cytosol of the cell, where it can be utilized in the process of respiration by the mitochondria. So, if there's a reduction in the amount of glucose transported into the cell, what's that going to do to the amount of glucose left in the blood and tissue fluids? Well, if less is transported into the cell, there's going to be more in the blood and tissue fluids. Therefore, there's going to be a hyperglycemia. The amount of sugar in the blood will rise. Now, where is hyperglycemia detected in the body? Whereabouts in the body are increasing levels of glucose detected? Well, these are detected in the beta cells. This is detected by the beta cells. So when the blood sugar level rises, that's detected in the beta cells. And how do the beta cells respond? Well, the beta cells respond by producing more insulin. So when insulin resistance starts, that is when insulin is made but can't be utilized properly because of the defective insulin receptors. Then what actually happens initially in the first months or even few years of the disease is that more insulin is produced. So in the initial stages of type 2 diabetes, there is actually a hyperinsulinemia. There is an increase in the amount of insulin in the blood. And what this will do is it will work the insulin receptors that are left all the harder, and they can actually facilitate the transportation of more glucose into the cell. So initially, there's a reactionary, compensatory hyperinsulinemia, and this is able to compensate for the defective insulin receptors and actually maintain relatively normal levels of blood sugar for a while. But then, because the cells have been overworked, because the beta cells have been overworked, they actually will stop working. And over time, there will actually be a reduction in the beta cell mass. Actually, there's depositions of nasty amyloid proteins in the beta cells, so quite what's going on I'm not too sure about. But I've always thought that the obligatory high output of insulin means that they're overworked and they wear out, and that is a reasonable way to look at what's going on here. Then after that, there's a period of impaired glucose tolerance where the patient's blood sugar will remain high for a period of time after a glucose challenge. And then after that, as the disorder of the insulin receptors goes on getting worse, and as the beta cell mass reduces, then there's kind of a double whammy here. There's less insulin receptors, and because the beta cells are wearing out, there is going to be less insulin as well. So that means that the blood sugar levels will progressively rise. And a reasonable definition, as we've talked about before, provided by the World Health Organization, when random blood glucose levels go above 11.1, or when fasting blood glucose levels go above 7, we should suspect that diabetes is present. So insulin resistance presents first in type 2 diabetes. And this is associated with other conditions that you might see. It's often associated with central obesity, abdominal fat. And it's often associated with hypertension, high blood pressure, and dyslipidemia. Now, dyslipidemia is associated with high levels of harmful LDL, that is low density lipoprotein, and low levels of protective and helpful high density lipoprotein. You might remember that these are the two forms of cholesterol. And the way I think about this is that the low density lipoproteins takes fat from the cells of the body and the liver and dumps it in the blood, so it's increasing the amount of fat in the blood. Whereas HDLs, the protective form of cholesterol, the protective high density lipoproteins, they do the opposite. They'll take fat from the blood, take it out of the blood and store it in the cells and store it in the liver. So they're reducing the amount of fat in the blood. So associated with type 2 diabetes is dyslipidemia, where the LDLs are too high and the HDLs are too low. And this combination of central obesity, hypertension and dyslipidemia is often called the insulin resistance or the metabolic syndrome. And just in passing, it's worth mentioning that another early feature, especially if the diabetes has been unrecognized for a while, is that we should send off a urine sample from these patients to test for microalbuminuria, because that's an indication that the microvascular disease is already starting to affect the kidneys. And that's an important point there, actually. Very often, patients with type 2 diabetes mellitus don't recognize it, possibly for several years, and it might only be picked up at a routine examination. So whenever you're assessing any patient, you always need to check and make sure there's no glucose in their urine, and do a BM test to see what their blood sugar levels are. Because although a patient might not suffer from any clinical features of type 2 diabetes, or no features they're aware of, that doesn't mean to say that the diabetes is not causing long-term harm to the body, and that the patients are already starting to develop the long-term complications. Because they will be starting to develop the long-term complications. And the poorer the diabetic control, the more likely they are to develop these long-term complications. So we have to have a high index of suspicion in any adult, really, but especially if they're obese, hypertensive and dyslipidemic, that they might have type 2 diabetes mellitus. Because all of these factors, of course, contribute towards vascular disease. Intra-abdominal fat is particularly harmful because it's metabolically active and releases free fatty acids. And these fatty acids, what they do is they actually compete with glucose in the mitochondria. So if there's lots of free fatty acids around, then some of those will be utilized in the energy production in the mitochondria. That means less glucose will be used, and of course that's going to contribute towards the hyperglycemia, because less glucose is going to be used. And central fat around the abdomen, also releases cortisol, and it has endocrine functions. And It's basically bad news. It's problematic. It causes this metabolic syndrome. Lack of exercise is another important factor. If you exercise, then you're going to be using up sugar. And if you increase the amount of glucose in the blood, then the increased amounts of glucose, of course, will be detected by the beta cells, and they'll produce more insulin. And the insulin will be binding to the insulin receptors. And it is this constant binding of the insulin with the insulin receptors that seems to wear out the insulin receptors. It's the same idea when we overeat. If we overeat, especially sugars and carbohydrates, sugary foods, then this will increase the levels of blood glucose. That will increase the levels of insulin in the blood. That means there's more insulin binding to the insulin receptors. And of course that's going to wear out the insulin receptors. The more they're used, the more they seem to wear out. So overeating and lack of exercise can both contribute towards insulin resistance in pretty well much the same way, by increasing the amount of glucose, increasing the amount of insulin, therefore increasing the usage of the insulin receptors. Of course, in our society there's quite a few of us overeat, overindulge in alcohol and don't exercise enough. How come is it that some patients get diabetes mellitus type 2 and others don't? Well, there is a genetic factor in diabetes mellitus type 2, as indeed there is in type 1 that we talked about. And 3 genes have been identified by geneticists that predispose towards diabetes type 2. And what's interesting is in monozygotic twins, remember twins that come from the same zygote, that is identical twins with exactly the same genetic makeup, then if one identical twin gets it, it is very, very likely, it's almost 100% concordance rate between monozygotic twins, indicating a fairly strong genetic basis for this condition, or genetic predisposition for this condition. And younger brothers and sisters have about a 50% correlation of getting the condition. So if one sibling gets it, there's about a 50% chance that the other one will, although this does reduce with increasing age. So how does this tie in with all the lifestyle factors we were talking about? Because remember, we've talked about lifestyle factors. We've said that overeating, hypertension, obesity, lack of exercise, eating sweet foods are all going to exacerbate the condition. Eating fatty foods is going to exacerbate the condition because fats are metabolized, and that increases insulin resistance, as we've noticed. And indeed, from epidemiological studies, we've noticed that patients with a very high BMI, a body mass index, have got 10 times greater risk than others of developing type 2 diabetes. So how do these genetic and environmental factors work together? Well, people are born with a genetic predisposition to the disease. They are predisposed to it. And that means if they have these adverse lifestyle factors, then it becomes likely they're going to get the disease. Whereas if they don't have these adverse lifestyle factors, that they may not get the disease, or they will get the disease very much later. So if someone's got a genetic predisposition to the disease, and they have adverse lifestyle factors, then they might get diabetes mellitus type 2 when they're 40. Whereas if they have a healthy lifestyle, they're active, they don't overeat, they keep thin, lots of physical exercise, not too much alcohol, then they might develop the disease when they're much older, when they're in their 70s. So it's a genetic predisposition. And what this means is if someone has got relatives with diabetes, then type 2 diabetes, that means they've got a predisposition to it, and they need to be even more careful about their lifestyle. People from the subcontinent are more prone to diabetes mellitus type 2, so they should be even fitter and even thinner than people who are white English people, just to have the same level of risk, because people from the subcontinent, India, Pakistan, are way more prone to developing type 2 diabetes. I mean, in some parts of India now, diabetes mellitus type 2 is almost an epidemic. You know, it seems like half the population's got it in some Indian states, although I'm not quite sure about the precise epidemiology. So genetic predispositions and environmental factors, both very important. And the disease is common even in the UK. 10% of the population over the age of 65 has got type 2 diabetes. It's just a common disease. Most cases are occurring, 70% of cases are occurring over the age of 50. So it is affecting older people, as is consistent with the idea of calling it a maturity onset diabetes. Now, there is another form that affects young women who are pregnant, gestational diabetes. So some women who were not diabetic will develop diabetic features when they become pregnant. And of course, in prenatal testing, well, before birth, when a woman knows she's pregnant, it is prenatal testing, isn't it? In prenatal testing, one of the first checks is always to make sure that the blood sugars are okay, because if they're not, they tend to develop very big babies, oversized babies. So the diabetes, if it develops in pregnancy, needs to be controlled. And this is actually significant, because if a woman has developed gestational diabetes, she is way more likely, there's actually an 80% chance that she's going to develop type 2 diabetes mellitus later in life. So particularly important if a woman has had gestational diabetes, that she's very careful about her lifestyle factors thereafter. Now, we haven't looked at long-term complications yet, but let's just look at why, briefly, it's so important to prevent diabetes if we can, and to manage it effectively if it does come along. Because 70% of, let's think about the causes of death. 70% of people with diabetes, the actual cause of death is cardiovascular disease, because diabetes contributes greatly to macrovascular disease. And of course, this is going to affect primarily the coronary arteries, greatly accelerating the development of coronary arterial atherosclerosis. About 10% of type 2 diabetic patients will die of renal failure, because again, there's an increased risk of renal failure. And there's an increased risk of infections and other complications of diabetes. Good glycemic control. If we can keep the blood sugar levels down, that's going to reduce retinopathy and nephropathy, and it probably helps to reduce macrovascular compensations as well. So how are we going to assess patients with type 2 diabetes? Because bearing in mind these risk factors. So the initial assessment should include a complete medical history with specific emphasis on the cardiovascular risk factors, because the cause of death in the patient in front of you is most likely to be cardiac. So what's their blood pressure, what's their lipids, what's their obesity level, what's their thyroid levels, all of these things. We should also test for neuropathy. What's the feeling like in their feet, what's the circulation like to their feet, and be aware of the complications and assess the patient to see if any of these are present. And if there are cardiovascular risk factors, we can correct these. If the patient smokes, it's absolutely vital that they stop smoking. Smoking is an absolute contraindication in diabetes, because it's such a risk factor for cardiovascular disease. If the patients are hyperlipidemic, of course, they're going to need statins to bring those down. If the patients are hypertensive, again, we can treat that. We would probably start them off on some ACE inhibitors or something to bring their blood pressure down. If the thyroid levels are too low, we can treat that by giving them some thyroid hormone. So, advice on lifestyle methods to improve glycemic control. Tell them what to do to improve glycemic control. And let's think about some tips we can give them there. If the patients lose weight, glycemic control will be improved. These patients need to be slim. They need to be. We need to avoid obesity. And of course, they need to take a lot of regular exercise. Regular exercise will burn up calories as the exercise is being taken, but as well as that, it will increase the metabolic rate and help the patient to lose weight. And of course, exercise is going to use up the sugar, which is going to reduce the amount of insulin the beta cells have to produce, which will reduce the wear and tear on the insulin receptors. So physical activity, very, very important for weight loss, diabetic control. And physical exercise also helps with lipid levels. It raises high-density lipoproteins. So these patients have to lose weight, and we really want them to take plenty of physical exercise. And we need to give them dietary advice as well. We want to avoid sugars, because when people eat sugar, that will rapidly increase their blood sugar levels, because sugar has what's called a high glycemic index. Now, a glycemic index of 100 would be pure glucose. So if people drink pure a solution of sugar, that's described as a glycemic index of 100. It puts the blood sugar up very, very steeply. But foods with lower glycemic indexes, the glucose is absorbed more slowly into the blood. So, for example, if you take complex carbohydrates, they're broken down more slowly, so the blood levels rise less dramatically, and the sugars stay in the blood for longer. Because if you eat sugary foods, the blood sugar level rises very rapidly, and that means that the insulin is obliged to rise very rapidly as well. That increases the amount of insulin in the blood, and of course we know it's the insulin in the blood which wears out the insulin receptors. So we want to be going for foods with a low glycemic index, and you can get tables of these. Complex carbohydrates, fruits and vegetables very often have lower glycemic indexes, whereas sugary foods have high glycemic indexes. So avoiding the sugary foods is good. And the dietitians at the moment are saying that the energy intake should be 55 to 60% based on carbohydrates, 15 to 20% based on proteins, and 20 to 30% based on fat. And that basically means a relatively high carbohydrate but relatively low fat diet. But of course, taking these carbohydrates in the forms of complex carbohydrates, not in the form of sugar. And dietary fibre is also very important. Dietary fibre helps to fill us up. It makes the bowel work properly. But as well as that, water-soluble fibre especially can help with serum lipid control. Plenty of fibre can actually reduce nasty cholesterols in the blood. Now this podcast is going on for a bit, so I think I'll stop now. But we'll just mention treatments actually first. Right. Well, traditionally there's been 3 levels of treatment for type 2 diabetes. Firstly is dietary control, and here we want to keep blood sugar levels down by not eating sugar, by avoiding the high glycemic index foods. So first level of management is dietary control, along with the exercise and the weight loss. The next level of control traditionally has been oral hypoglycemic preparations, that is oral medication to reduce blood sugar levels. And the third line of treatment traditionally, when these aren't working anymore, has been to start giving the patients insulin. The thinking on this is changing now, though. Quite a few studies are showing that if insulin is given at a much earlier stage of the disease, this actually rests the beta cells that are there. It's called a beta cell rest. So if we actually give the patients insulin at an earlier stage in the disease, it means the patient's own beta cells are not obliged to produce as much insulin, so they don't wear out. And there is some indications now that that's associated with a better prognosis if we give insulin earlier in the disease process rather than keeping it as a reserve. And the insulins we give now are 100 units per mil. The short-acting ones, intermediate and longer-acting ones that I'm sure you're familiar with if you look around your drug cupboards. And then there's oral hypoglycemics as well. And there's the group called sulfonylureas. This is the glibenclamide and glycoside type oral hypoglycemic. And they stimulate the beta cells to produce more insulin. And they probably inhibit insulin degradation as well. And actually they may increase insulin receptor density, making more, stimulating the insulin receptors. And then the other group, the metformin types, that's the big UAnides, the metformin type. These increase the glucose entry into muscle cells, and they also seem to inhibit the amount of glucose that the liver produces in the process called gluconeogenesis. Right, I think that'll do for now. Probably the final part of this diabetes podcast, the next part, will look at the long-term complications.